Our distinguished speaker for this morning is Dr. Andrew Dauber. He's currently the Chief of Endocrinology at Children's National in DC. Dr. Dauber earned his MD and medical degree, a master's degree in clinical investigation at Harvard Medical School, and completed his pediatric residency, chief residency, and pediatric endocrinology fellowship at Boston Children's. At Boston Children's, he began his research under the lab of Dr. Joel Hirschhorn, and his work focuses on rare genetic causes of growth disorders and the use of next generation sequencing technologies to understand pediatric endocrine disorders. He's identified many novel genes for both short stature and puberty. After his time in Boston, Dr. Dauber was the inaugural program director for Cincinnati Children's Growth Disorders at Cincinnati Children's. And since 2018, he's moved to Washington, D.C., and in his current position as the Chief of Endocrinology at Children's National in D.C. He's currently leading clinical trials, exploring the use of many drugs in children, and involved in many research projects, many societies, won many awards, Young Investigator Award at the Peds Endo Society, the Richard Weitzman Outstanding Early Career Award from the Endocrine Society. So we're honored to have Dr. Dauber with us. We'll let you take it away. Thank you.
Awesome. Well, thank you very much. Thank you for the introduction and for the invitation to join you. I'm sorry that I couldn't be there in person. I am currently on father duty as my wife is out of town. So I apologize in advance if we have any childcare induced interruptions, but I don't think we will. Well, today I'm going to be speaking to you about novel therapeutic approaches to short stature. These are my disclosures. The most relevant ones for today's talk is that I do have research support from BioMarin, and I'm going to talk about a clinical trial that I'm doing with that support. And I am a site investigator in the Lumos trial, the oral growth trial, although I don't receive any personal compensation for that. So today we're going to start by giving you a little bit of an overview about this novel oral growth hormone secretagogue called LUM-201. We're then going to spend the majority of the talk talking about various molecules that target the FGFR3 CNP pathways, primarily for new treatments for achondroplasia. And then I'm going to give you some hot off the presses preliminary data from my current trial of vosoritide for selected genetic causes of short stature. And finally, I'm going to end with just a very brief story about an approach for a very rare skeletal dysplasia called metaphyseal chondrodysplasia Schmid type. And I like to start my talks, and some of you may have heard this before, thinking about the diagnostic and therapeutic approach in the growth hormone era. So you're all, I think, aware that recombinant human growth hormone has been around since the mid-'80s and has been the major player as our therapeutic option for kids with various growth disorders. And I really think about the whole way we've been practicing for the last few decades can be summed up with two parables or stories, right? So this is the first one. The first one is about the man who's down on his hands and knees on a street corner. And another man walks by and he says, "Hey, did you lose something? Can I help you?" And the first man says, "Yes, I dropped my keys. I can't find them." So the second man says, "Okay, let me help you out. I'm going to help you find them. Is this where you dropped your keys?" And the first man says, No, I dropped them down the block over there." He says, "Well, if you dropped them down the block, why are you searching here?" And the man replies, "Well, this is where the light is," right? And I think for many of us, this is a very apt adage for how we approach growth disorders, right? So we are endocrinologists. We're taught about hormones. And we're taught to think about the hormonal evaluation of kids with short stature. And we're very familiar with thinking about growth hormone and IGF-1. We're familiar with measuring hormones, with doing growth hormone stimulation tests. And that was where the light, our understanding for growth disorders lied. And I'm going to posit that really in the last decade or so, there's been a whole new light from genomics, a whole new understanding of height and short stature based on genetic insights, and that we really need to change our paradigm for how we approach kids with short stature. And of course, the second adage is when all you have is a hammer, everything looks like a nail. And really, for decades, outside of maybe the rare use of recombinant IGF-1, all we had as an option for treatment was growth hormone. And therefore, all of the studies and the way we thought of things were, is somebody growth hormone deficient or resistant or IGF-1 resistant? And, how can we best treat with growth hormone? So my hope now is that we're entering an era where there could be more precision medicine approaches. All right, so starting out, let's talk a little bit about LUM-201, which is this oral growth hormone secretagogue. So this is actually a very interesting story. So actually a while ago, Merck was looking for drugs that could increase growth hormone secretion from the pituitary. And they did a whole bunch of, in vitro experiments, and they found this molecule. I don't remember what they initially called it. Now it's called LUM-201. And it bound to a receptor which was called the GSR1A, the growth hormone secretagogue receptor. Subsequently, it's been found that this is the receptor for the endogenous hormone ghrelin, okay? But this molecule, LUM-201, it's an oral molecule that binds to this receptor both at the level of the hypothalamus and at the level of the pituitary. And by stimulating this receptor, you can increase the amplitude of endogenous growth hormone pulses. And as a result, with more growth hormone, that can go to the liver, go to the bone, and increase IGF-1 production. Now, what's different about this than giving exogenous growth hormone is that the feedback loop from IGF-1 back to the hypothalamus and pituitary is still intact, right? So theoretically, what this molecule can do is kind of restore growth hormone release maybe back to a normal physiologic level, but it can't push it too high because as the IGF-1 rises, the IGF-1 will have negative feedback and suppress further super physiologic growth hormone release, right? Which is very different from what we do with exogenous growth hormone, where you can just jack up the dose, and try and continue to push that IGF-1 higher and higher in some conditions. So this is kind of a little bit of a different paradigm of trying to return patients with growth hormone deficiency for some reason back to a normal level of growth hormone release. And there's currently a phase 2 study, which is ongoing, comparing 3 different doses of LUM-201, which is the name of this medication now, versus daily growth hormone. Actually, I should amend this. It's now actually a 24-month study. Ignore that on the slide, in children who are prepubertal with growth hormone deficiency. These are not the results of this trial, but this is a result from that earlier Merck trial. And what's really interesting is that before designing the current trial, they looked back at the data and realized that not everyone was going to be a great responder to this medication, that certain individuals are more likely to respond and others are less likely to respond. So in order to get into the current trial, you had to pass what they call a predictive enrichment marker, meaning that you have pre-selected to be more likely to respond. So where did that data come from? So let's look at, this is the kind of post hoc analysis of the initial trial. And if you look at the all subjects, right, there was the placebo group. There was a group that received what is now the lowest dose of LUM-201 in the current trial, and a group that received recombinant human growth hormone, and actually a pretty generous dose. And what you see is that the individuals who were treated with LUM-201 with growth hormone deficiency did have an increased height velocity compared to placebo, but not nearly as good as the patients who received growth hormone, who grew at a much higher rate. That's, on the left, all subjects. Then, however, if you divide these people based on whether they met this predictive enrichment marker, meaning that they had an IGF-1 level above 30 at baseline, and when you gave them a test dose of the LUM-201, they could increase their growth hormone to above 5. So if you divided that, the people who were PEM negative who didn't pass that, they didn't respond to Lume 201 at all, right? And the ones who were treated with growth hormone had a great response, right? Even more response. However, the people who were PM positive, not only did they respond to Lume 201, but the difference between treatment with growth hormone and Lume 201 was not statistically significant at all. And if you go to the bottom table, looking at the distinction between these two people, it's pretty obvious who they are, right? So the people who failed the predictive enrichment marker, if you look at their height SDS, they were at minus 4.6 ST compared to minus 2.6 ST, right? They had much more severe growth hormone deficiency. Their pre-treatment height velocity was lower. Their growth hormone peaks were 1.7 versus 7.1. And that makes sense. You could imagine that people who have severe growth hormone deficiency might not have an intact hypothalamic pituitary axis and therefore are not going to respond to this medicine that's trying to increase endogenous secretion. While people with milder growth hormone deficiency, whatever that is, may be able to respond. And similarly, people with growth hormone, treated with growth hormone, the more severe patients we know always have a much better response. So that was interesting. So after looking at this data, they decided to do a study specifically looking at the patients who would pass this predictive enrichment mark. So here are some hot off the presses data. This data was released by Lumos, the company doing the trial, in a press release to investors. This has not yet been published or peer reviewed. And I'm hoping that more details of the data are going to be presented in detail at the Pediatric Endocrine Society coming up in May. And I know you're all at PESTOLA, but you should also come to PES in San Diego. It's going to be a great meeting. Anyway, so if you look here, on the left is the results from the current trial. Now, these are interim results, okay, of only half of the patients at 6 months. All right, so these are not by any means the final results. And you can see the 3 doses of Lume 201, the 0.8, 1.6, and 3.2. So 0.8 was the dose they used in the prior trial. Now they're using higher doses as well. And what you see is that the individuals who were treated with that 1.6 dose achieved a growth velocity of around 8.6 centimeters per year. Now, the individuals treated with growth hormone did achieve a higher growth velocity of 11, and we'll talk about that in a second. But if you compare that 8.6 to what was expected, okay, that is a very good response for people with mild growth hormone deficiency. So if you look at data to the right from the prior Merck trial, the recombinant growth hormone arm only grew at 8.8. If you look at data from large, retrospective databases like the KIGS database or some of these other studies looking at patients with isolated growth hormone deficiency, the expected growth is only in the kind of 8.3, 8.5 centimeters per year. So it looks like this Lume 201 arm is doing as well as one would expect for patients with isolated growth hormone deficiency. Now, why did the patients getting treated with growth hormone grow so much better? And some of this we have to wait and see when the full data set comes out. There were a few outliers. Actually, one of them is one of my patients in the trial, a younger patient who had more severe growth hormone deficiency, who grew for real at like 14 centimeters a year or something. So there were a few outliers that really were driving that number higher when you have small data. And we'll see what happens when the data pulls out, in full. But I think this is something you should be aware about. It's a very interesting thought to consider what the role could be for an oral medication that could be effective in patients with milder growth hormone deficiency with more perhaps modest results than seen in patients with growth hormone with severe growth hormone deficiency. But more to come on that in the future. Okay, so changing gears, we're now going to move and talk about the growth plate. I heard Jeff Barron spoke with you guys, so I'm sure he showed a picture that looked like this. So on the left is a cross section of a growth plate. You can see the different zones, the resting zone, the proliferative zone, the hypertrophic zone, and then the new metaphyseal bone being formed through this process called endochondral ossification. And when you look at those zones you see in them, those little circles, those are the chondrocytes, right? Those are the cells that produce new cartilage and help actually expand the bone. And on the right here, we have the zoom in of a single chondrocyte, showing some of the signaling pathways within the chondrocyte. And I'd like to draw your attention to the pink receptor in the kind of top left that's labeled FGFR3. So FGFR3 stands for fibroblast growth factor receptor type 3. You may know that this is the receptor that is mutated in achondroplasia and in hypochondroplasia. So in individuals with achondroplasia or hypochondroplasia, you have an activating mutation of FGFR3, so it turns it on. And if you follow those signaling pathways down, that leads to impairment, inhibition of chondrocyte proliferation and hypertrophy. So FGFR3 acts as a brake on growth in the chondrocyte. And if you look down, if you follow that around to the right, you see this pathway, which you might have heard about, the RAS pathway, the RAS, RAF, MEK, MAP kinase, also called the ERK pathway, which inhibits chondrocyte hypertrophy. Now, in the top right of the cell here, you see a second receptor called, encoded by the gene called NPR2. Okay, and that is the receptor for CNP. CNP stands for C-type natriuretic peptide. CNP binds its receptor, NPR2, the protein's called the natriuretic peptide receptor type B, but it encodes that, and that pathway actually inhibits that RAS, RAF, MEK, MAP kinase pathway. So it actually acts to promote growth. It lifts up that brake and tells the cells to continue to grow in hypertrophy and increase growth. So there have been a number of strategies now that are under development or actually in production to see if they can improve growth in individuals with achondroplasia. So why achondroplasia? Well, for two reasons. One, achondroplasia is the most common of the skeletal dysplasias, causing short stature. And second, it also has a lot of medical comorbidities associated with it. And the hope is that if you can improve growth, you might also be able to improve some of those significant medical comorbidities. So one of the strategies that's been employed is to develop analogs of CNP to try and impose that pathway. Another is something called a soluble FGFR3 receptor, kind of a decoy receptor that will bind to FGF3, in circulation and prevent it from binding to its receptor. There are other specific inhibitors of the tyrosine kinase in the FGFR3, blocking its signaling, and downstream blockers as well here between MEK and MAP kinase. So we'll talk a little bit about that. So before doing that, let's just go and focus on what is CNP's job. And this is actually work from Dr. Barron's lab, published back in 2000 by Veronica Marique. And what this shows is that this was in a culture of, I think it was rats, like fetal metatarsals, of like growth plates from the rats. And if you added CNP to the mix, it would increase the growth rate of those growth plates. And CNP was found to increase the chondrocyte proliferation in the proliferative zone. It increased the number and the size of those hypertrophic chondrocytes, and it stimulated the production of more of the matrix, right? The goo that's around the cells that is important for lengthening the bones. And there's some interesting human data. There are individual patients out there who have overexpression of the CNP gene. There's a translocation that leads to increased CNP expression. As you can see from the pictures, these people are very tall. They kind of look like similar to Marfanoid habitus. They have very long limbs. They have long fingers, arachnodactyly. Specifically, also, they have very long, big toes, which you can see there. And a number of them have scoliosis associated with their significant tall stature. And similarly, there are individuals who have increased CNP signaling because of activating mutations of that receptor, the NPR2 receptor. So pictured here is a man who's 7'3" tall. He has a gain of function mutation in the NPR2 receptor, and there are a number of different patients who have been described with this as well. Also very rare. But just to show you that if you have lifetime increased signaling of CNP, it will lead to taller stature. And on the flip side, if you have a recessive mutation, both of your copies of NPR2, that receptor, are not working, you have a significant skeletal dysplasia called acromesomelic dysplasia meritotype, okay? But what's very interesting about this was in this original article in 2004, where they described the gene that causes the skeletal dysplasia, they also looked at the relatives, okay, the parents and siblings who carried just one copy of the mutated gene. And they found that those individuals on X-ray, they looked normal, right? They didn't look like they had skeletal dysplasia, but they had short stature. They had what appeared to be idiopathic short stature. And subsequent to that, there have been numerous groups who have looked to see how common it is for individuals with idiopathic short stature to have mutations in the NPR2 gene. And it's probably around just under 2% of cases of individuals with idiopathic short stature have mutations in NPR2. I want you to pause and just think about that for a second, right? That means just under 1 in 50 of every patient you see with idiopathic short stature could have a mutation with NPR2, right? Probably the people in this room have seen in the last year thousands of patients with idiopathic short stature, right? So there are a lot of people out there with mutations in NPR2. Okay, so I've shown you now that individuals with loss of function mutations have short stature and gain of function mutations have tall stature. So this is, an ideal target for developing of therapeutics. A number of companies have gone that route. And the one that's furthest along is a drug developed by BioMarin called vosoritide. And when it was in early development, it was called BMN 111. And this is animal data. This is mouse data showing that in a mouse model of achondroplasia, when you give increasing concentrations of vosoritide, it can increase growth in the mice, and it can rescue histologically the abnormal histology that's seen in achondroplasia in the mouse. So taking this forward, this moved into human trials, and this was published in 2019 in the New England Journal. This is the phase 2 study results. This was a dose-finding study of 4 different doses of vosoritide in children with achondroplasia. And what they found is that the 2 highest doses, which were 15 and 30 micrograms per kilogram per day, there was an increase in growth velocity in those treated with vosoritide, and that was sustained over multiple years. So they went on, of course, and moved to a phase 3 trial, which was published in The Lancet in 2020. And this was a placebo-controlled, double-blind, randomized trial comparing placebo to vosoritide at the dose of 15 micrograms per kilogram in individuals with achondroplasia. And what you can see on the left is that at week 52, the individuals with achondroplasia grew on average approximately 1.6 centimeters more per year compared to those who received placebo. Now, 1.6 centimeters per year, it does not sound, as robust typically as we think about growth hormone deficiency. But this is a very different disorder. And if you think about, if you can do this for many, many years, it has the potential to change somebody's height by, 10 or even more centimeters if it's sustained, which it appears to be in the ongoing data. And pictured on the right here is a forest plot just showing that these increases in growth velocity were true in essentially all of the subcategories. It didn't matter your age or how severe your height deficit was at the beginning of the trial. They essentially all responded to vosoritide pretty similarly. This is now the 2-year data. So on the left, the graph looks at the growth velocity. So the red is those receiving placebo and the blue is those receiving vosoritide. And what you can see here, which I think is pretty nice, is the first from week -26 to baseline. That's a 6-month observation period where they had very similar growth velocities, around 4 centimeters per year. And then the group treated with vosoritide, as you saw, this is the same data as on the last slide. They increased their growth velocity by around 1.6 centimeters per year. And then in year 2, all of the patients who received placebo were crossed over to vosoritide, and their growth velocity therefore picked up and was very similar to the patients who were treated, who are now having a sustained increase. And on the right is looking at the body proportions. So individuals with achondroplasia have obviously significant disproportionate short stature as it affects the limbs more. And this is just showing that by year 2, you begin to see a statistical improvement in body disproportion. The magnitude is still extremely small, the difference, but again, the hope is that with multiple years of treatment, you could see improvement in body disproportion, which has functional implications, for living in our world. Okay, so that's it on vosoritide. So another approach to modulate CNP is through a long-acting form of CNP called TransCon CNP. It's a sustained release form. And this is data from animal studies. On the right here, this is actually from monkeys, showing that at the higher doses of the TransCon CNP, it significantly increases body length, tibial length, ulnar length, tail length. So if you have a patient with a tail who wants it longer, that's great. So some good preliminary animal data, suggesting that TransCon CNP could be beneficial. And they moved also into human studies. And here are the phase 1 results. And on the left is the pharmacokinetics results, just showing that at different doses, you get a dose-dependent response in concentration, as one would expect. But what was really exciting from the phase 1 results is the pharmacodynamic data on the right. So urine cGMP is just a readout of that NPR2 activity. The details are not important, but it's a readout of showing that you're kind of hitting your target and increasing signaling. And what you see is that at those higher doses, you have a significant increase in the cGMP, which is sustained up to day 8, right? Supporting a once weekly administration of TransCon CNP. So again, hot off the presses data. This is also has not been peer reviewed. This is data that was released to investors on the website. And this is of the phase 2 trial of children with achondroplasia between the ages of 2 to 10 years. There were a total of 57 subjects in the trial. Enrollment is complete, 15 with placebo, 4 doses, as you can see here, for a total of 52 weeks. The safety profile looked pretty good. And if you look at the highest dose, the lower doses did not have a significant increase in growth rate compared to placebo. And at the highest dose, there was a mean growth velocity of 5.4 centimeters a year compared to 4.3 for placebo. So only around a 1.1. Now this is, a small phase 2 study, but a 1.1 centimeter increase compared to placebo. And I believe this is continuing into other ongoing trials. So we'll wait to see larger cohorts in a phase 3 data. It's hard to compare data across trials, so I'll leave it at that, but this is what the data shows for now. Okay, moving into other medications, I'm just going to mention for a second, there was a medicine called Reciprocept, which was that decoy receptor for FGFR3. The idea is that it would bind the FGFs and prevent them from binding to the receptor. There was animal data suggesting it looked good. However, just announced that this trial has been stopped. I don't know why, I'm not involved, but the program has been killed, and this will no longer continue development. They have not published yet the results from the ongoing phase 2 studies, but presumably the results were not awesome, or the trial probably wouldn't have been stopped. So this sounds like this will no longer be an option in the future. So moving to our next option, there's a medicine called infigratinib, which is a tyrosine kinase inhibitor. And it is specific to not just FGFR3, but FGFR1, 2, and 3. And it reduces the phosphorylation of that tyrosine kinase domain and therefore blocks signaling. This medicine is already approved for cholangiocarcinoma, because there's some forms of cholangiocarcinoma that have FGFR mutations. And it is an oral medication, which is really nice. And in that same mouse model that was used for vosoritide, there was actually an even larger effect on growth in the mouse model. Excuse me. So infigratinib also has a phase 2 study underway. Again, data has been released on their website to investors and has not yet been peer reviewed. This is a study in children between 2.5 and 10 with achondroplasia. The study that they've released the data on is about 4 different doses for 6 months. And it was overall very well tolerated. At the 3 lowest doses, there was really no significant increase in growth velocity. But at the highest dose, in the children over 5 years, there was an increase in height velocity of 1.52 centimeters per year. That's supposed to be saying kids age over 5 years. So significant compared to placebo. And in that highest dose, 64% of those subjects had an increase in their height velocity by more than 25%. Given these encouraging results, they have now actually added a 5th cohort at an even higher dose, thinking that they had not necessarily hit the plateau of the effect. And those data are pending at this time. Okay. And finally, the last drug we're going to talk about is meclizine. So you might remember meclizine, right? It's used for motion sickness. And this group was doing a large unbiased drug screen. And they found that in vitro, meclizine blocked that downstream ERK phosphorylation. And in a mouse model, it improves statistically achondroplasia growth in achondroplasia mice. There was a phase 1 study in Japan examining the PK. There seems to be a phase 2 study in Japan, although I can't find any results of that. And I know a group in South America is also trying to look at this as well. So hopefully we'll get some results of this drug, which is cheap and available, to see if it can be helpful. All right, so switching gears, I'm now going to tell you about my trial. So I thought that this medication, CNP analogs, could be helpful not just for achondroplasia, but for many other conditions. So I had approached BioMarin about doing a trial, and then after some discussions with the FDA, I was able to obtain approval for doing a trial for 6 different selected genetic causes of short stature. So one is hypochondroplasia, which is pretty obvious, right? Same rationale as achondroplasia. The next are individuals with deficiency of the CNP gene, which is very rare, but if you're missing that, we should just be able to replace it. Individuals with heterozygous mutations in the NPR2 gene, hoping to restore signaling to normal. The whole category of restopathy, so the one obviously we're most familiar with is Noonan syndrome, but also Costello's, CFC, NF1, and individuals with Noonan syndrome, as you're aware, many of them have short stature due to increased signaling through this RAS pathway. And I was thinking that this is a really precision-targeted approach. SHOX mutations, a SHOX can decrease FGFR3 expression. And finally, individuals with aggrecan deficiency. We'll talk about these each just a little bit more. So in 2018, there were 2 patients identified with mutations in the CNP gene out of a cohort of 340 with short stature. Both of them had dominantly inherited short stature, inherited from one parent, and their height was a range of short stature. And I have not been able to find any more patients with this, but if one shows up or you find somebody with it, let me know, because I would love to see what happens if we can give them vosoritide. For NPR2 deficiency, this was data done by a guy named Carol Estrada when he was working at BioMarin. And what they did was they made in cells, in rat chondrosarcoma cell lines, they made cell lines with no NPR2 expression or 1 copy missing or wild type, and then added CNP. And what they were able to show was if you have no NPR2, obviously CNP can't work because it has no receptor to bind to. If you have wild type, if you add CNP, you are able to increase the signaling significantly. And even if you only have 1 copy, you don't increase it as much, but you're able to restore signaling significantly by giving CNP. So that's the rationale. behind people with the heterozygous NPR2 defects. And as I mentioned earlier, that might represent up to like 2% of idiopathic short stature. The restopathy pathway, I'm not going to go into all the details of the different restopathies, but again, CNP directly targets this pathway. And there have been animal models. This is a mouse model of neurofibromatosis of NF1, showing that if you give it CNP, it will grow better and rescue the abnormal histology in the growth plate. Here's a mouse model of cardiofaciocutaneous syndrome due to a BRAF mutation, another one of the restopathies, also showing improved growth with CNP. And I think many people are familiar with SHOX gene mutations. Around 2% of individuals with idiopathic short stature likely have SHOX gene mutations. And here's some data showing that SHOX binds to FGFR3 in the regulatory region and decreases its expression. So if you have a mutation in SHOX, you would have increased FGFR3 expression and signaling, and therefore make it a target for a CNP drug. And finally, aggrecan gene mutations. So aggrecan is a proteoglycan found in the extracellular matrix of the growth plates around the chondrocytes. And individuals with aggrecan gene mutations have dominantly inherited short stature. So they typically have one parent also with short stature. And around half of them, they often have an advanced bone age, but don't have to. And around half of the families will have significant early onset arthritis. Actually, one of the not unique, but if you hear that a parent with short stature had patellar dislocations or early onset need for a joint replacement, you should really think about an aggrecan gene mutation. And just as a plug for, I hope many of you know, there's a panel from Invitae called the Discover Dysplasia Program. It's their skeletal dysplasia panel. It's free, and it has both aggrecan and NPR2. It doesn't have SHOX on it, which is really a shame, but you can order it for free from your patients, with a simple saliva sample, and it has around 330 different skeletal genes on it. You'll get a lot of variants of uncertain significance, but it's an easy and free way to test for aggrecan and NPR2 mutations. And if you find someone, please let me know. All right, so with aggrecan, not all patients have severely advanced bone age, so there's really a range of short stature and bone age advancements. In a chick model, it was shown that aggrecan deficiency leads to also increase of that signaling pathway. So what's our trial? So we're looking at kids between the ages of 3 and 11 for males, 10 for girls, who are prepubertal with a height below -2.25 standard deviations. They have to have a documented mutation in one of those 6 categories and essentially are otherwise healthy. And they come to DC for 4 visits over the course of 18 months. We pay for all of their travel expenses. The first 6 months, we just do observation to get a baseline growth velocity. And then they come back and we start them on vosoritide. There's no placebo. Everyone gets vosoritide. This is a phase 2 study. At the dose of 15 micrograms per kilogram per day. We're doing pharmacokinetics and pharmacodynamics, and then we follow them up at 6 months and 12 months. And then for those who are having a good response, there is an extension phase as well, so they can continue. Here are the study outcomes. We're looking for safety, adverse events. We're looking at the change in growth velocity and change in height standard deviations. We're looking at body proportions, bone age, and as I said, PK, PD. We're doing some quality of life surveys and DEXA scans. So here we are. As of January 25th, we have 41 subjects who are screened, 3 of whom were too tall, actually, and 38 subjects enrolled, 2 of whom dropped out during the observation period. They just decided that the travel was too much for them, so they never got exposed to the medication. So 36 subjects actively in protocol. 16 of them have gone through month 12, 12 of whom are enrolled in the extension phase. 27 subjects completed month 6. 34 subjects are on vosoritide and 2 still in the observation period. 22 males, 14 females. And as you can see, the majority of the patients have hypochondroplasia, 24. But we have 4 patients with aggrecan gene mutations, 4 with NPR2, 3 with Noonan, and 1 with NF1. So we are actually still recruiting for the study. This study was initially supposed to be 35 patients, but it's been going so well that we expanded. We are no longer recruiting patients with hypochondroplasia. That cohort is closed, but we are recruiting for the others. In particular, if you have ACAN, Aggrecan, Noonan, or NPR2 patients, I would love to talk with them. So you can see the distribution of the ages. We have one on their third birthday, but otherwise you see a good range between 4 and 11. And their height at screening. So these bars mean that you're less than or equal to that bin. So one person below -5 standard deviations, 3 below -4, between -4 and -5, 17 it looks like between -3 and -4, and the remainder 15 between -2.25 and -3 standard deviations. So some pretty significant short stature there. So here's some preliminary results. This is the data on so far on the hypochondroplasia patients. So you can see at 12 months, there has been an increase in growth velocity. We have approximately 2 centimeters a year. That's only based on 7 patients. So nobody get too stuck to that number. But we see similar results at month 6 as well with 12 patients. So people are percolating through the trial, and by I think September, October, everyone will have finished 1 year. So looking forward to presenting those results when they're available. Though these are the results that I'm even more excited about. So hypochondroplasia looks pretty similar to achondroplasia, maybe a little bit better. But these are the results, of course, in a small number. But on the left, you see the patients with Noonan syndrome. So you can see that like the patient in green went from 2 to around 2.5 to around 7 centimeters a year, which is a pretty great increase. The one in blue went from 4 to 10 centimeters a year at 12 months, and the one in red went from 6 to around 9 centimeters a year. So we're seeing really impressive increases in growth velocity in our small number of patients with Noonan syndrome. They have all continued on into year 2. So we'll see how it continues. And on the right, you can see the increase in their height standard deviation scores as they continue on treatment. So more to come on that in the future. As I said, we're actually actively enrolling some more patients in that arm. So really a precision medicine approach to potentially the treatment of short stature and Noonan syndrome. And just quick snapshots of small preliminary data on the patients with NPR2, also really seeing some beautiful responses. The patient in red went from essentially not growing at all to now 10 centimeters a year. And the one in blue went from around 3 to almost 8 centimeters per year. We have 2 patients who have come back on with the Aggrecan gene mutation so far for their results. And you're seeing one going from 2 to 8 centimeters a year and the other one from 4 to 10. So really tremendous increases in growth velocity in these conditions. So we'll have to see if that's sustained and with more people. And overall, it's very well tolerated medicine. It is very common to get injection site reactions, which have all been mild. Nobody's had to stop because of that. We had no episodes of symptomatic hypotension, which can be a side effect of this medicine. We did have one patient who had an episode of syncope, but the blood pressure wasn't low. I can't really explain that. She was running around like a maniac with her IV in, and 2 episodes of pre-syncope, one which was a 10-year-old who was getting his blood drawn without getting any medication. We had one SAE, which was unrelated to the study drug, and one subject who had a significant progression of his scoliosis, which is being monitored. All right. So in the last few minutes, I'm going to turn now away from our trial to metaphyseal chondrodysplasia Schmid type. And again, this is just, I want to give you this example. This is not my work of a precision medicine for a rare disorder. So this is a mutation in the type 10 collagen gene. Its incidence is like 3 to 6 per million, so super rare. But they've shown the pathophysiology is that this mutant collagen 10 protein misfolds. It's retained in the endoplasmic reticulum of those hypertrophic chondrocytes, and it leads to what's called ER stress, and that affects the differentiation and therefore the growth of those chondrocytes. And again, like they did this unbiased drug screen, really beautiful study trying to look at already approved medications to see how they affect that ER stress markers in the cells. And they found that carbamazepine, which is an approved and available, medicine for epilepsy, rescued the growth plate phenotype. You can really see that dramatically. If you just look at the length of the yellow bars, which is the hypertrophic zone width, they show a real improvement in the carbamazepine treated, and in the animal model, you saw an increase in tibial length and femur length treated with carbamazepine. So a group in Europe led by the people at Newcastle University are now doing a multi-center trial of carbamazepine for patients with metaphyseal achondroplasia Schmidt type. Unfortunately, there are no sites in the US. I'll tell you, though, you could just try it if you wanted to. I mean, you have to just know a little bit about carbamazepine. I actually had one patient come to me with this, and we talked about it. We decided to try it, and unfortunately, he got a terrible drug rash from carbamazepine, so we had to discontinue treatment, after just a few weeks. That is a known side effect, and you do have to be careful because in patients with a certain HLA type, which is found in certain Asian ethnicities, they're at high risk for Stevens-Johnson syndrome. So you really want to check that before moving forward with carbamazepine. But we'll see what the results of this show, an interesting potential new approach to a previously untreatable disorder. So in conclusion, there are multiple novel therapeutic approaches for short stature on the horizon. Drugs that are being developed for achondroplasia may be of use in other causes of short stature. In the future, I believe that we're going to be using precision therapies targeted at the underlying pathophysiology of individual genetic growth disorders. And of course, I don't mean to at all suggest that growth hormone will not continue to play an extremely important role, not just in growth hormone deficiency and in other conditions, but it will be nice to have options for patients and additional targeted therapies. And with that, I am happy to answer any questions.
Thank you, Dr. Dauber, for that cutting edge talk. Any questions in the room?
While you're calling for that, I'll just answer one of the ones I see in the Q&A. So for the vosoritide patient study, Noonan patients do not need to be growth hormone naive. Actually, we have a mix. We've got a few more patients actually now. We have a mix of patients who are growth hormone naive who just, I asked them, why don't you just start on growth hormone? And some of them just like the idea of being a trial. Some of them, there are some people who are nervous about the idea of growth hormone in rhasopathies because of the malignancy potential. I don't want to feed into that fear, but there's some people who prefer to avoid it, so have wanted to opt for vosoritide as it shouldn't increase that risk. And then, but the other patients in the trial were previously treated with growth hormone, didn't feel like they had a great response. So they are eligible for the trial. They can't be on, they have to stop the growth hormone though. You can't be on growth hormone during the trial or during the observation period, but they're definitely eligible. I'll keep doing the chat, but please interrupt me if there are questions.
I'll ask a question. If so, I see in the vosoritide group you had the shocks deficiency, but did not have the Turner girls in there. So
great question. So great question. So that's right. And the reason for that, it's not that it shouldn't work in Turner syndrome. The reason was that when we started this trial, vosoritide had not yet been approved. Vosoritide is now approved for achondroplasia by the FDA, but when we started, it wasn't. The results for the phase 3 study had not been published yet. And I really wanted to, go as safe as possible. And because girls with Turner syndrome often have other, heart issues, I didn't know the full cardiovascular safety profile. It now looks like it's pretty safe. So we're thinking about whether that could be an area we could pursue for additional research. I will note we haven't recruited anybody for shocks deficiency because also, growth hormone works pretty well for those patients. So we haven't been able to recruit anybody into vosoritide, but I think Turner syndrome is definitely a potential indication as well.
So you mentioned the heart. So with the new NANs, there are certain subtypes that has the hokum and heart issues. We learned about that yesterday. So in that particular group where growth hormone is maybe not the best option, is that a particular subtype with vosoritide?
That's a great question. So we, in our study, allow most congenital heart disease, but actually, again, we excluded patients with hypertrophic cardiomyopathy, not because we thought it would have a negative effect on the cardiomyopathy, but because it can lower your blood pressure, and we didn't want to lower blood pressure in patients with hypertrophic cardiomyopathy. It is an interesting idea, actually, whether a CNP analog of any type might actually improve the cardiac outcomes in those patients. And there is no data about that I'm aware of. It's just more of a theoretical question. So I think that there might be future trials where those patients could be included, but right now, just hypertrophic cardiomyopathy is excluded from the trial because of that blood pressure concern, which I kind of wish I hadn't done, but we got to stay safe to start out with.
Are there other questions in the chat or any questions here?
Yeah, I see some questions. So the free skeletal dysplasia panel is by Invitae. If you type in just discover dysplasia in Google, it'll come up. And I think when you order it, you have to put in the code SKEL, like SKEL, and then it makes it free. So for full disclosure, that panel is supported by BioMarin. The reason has nothing to do with my trial. The reason is because they're looking for patients with MPS and, which they have other drugs for. I personally just am finding it a nice way to get free testing for my patients. But whatever. And let's see, how did the team come up with the growth hormone at level of 5 after the PEM stim, the initial research review? Okay, great question. Let me just make it clear that level of 5 is not a level of 5 on your typical like arginine glucagon or clonidine stim test. That level of 5 is a test dose when you give the LUM 201 at a certain dose, and then you measure it. I think it's 30 minutes later, or 30 and 60. I can't remember the exact timing. That the level goes up above 5, and that was a post hoc analysis. Basically, they did a post hoc analysis to look at that initial Merck study and see which patients were responders and non-responders. And that was one of the factors that differentiated the groups. I don't know the details of that analysis of like if they looked at other cut points. I'll just tell you anecdotally, LUM 201, and this is not just anecdotally, I mean, this data is being shown. It's a very, very potent growth hormone secretagogue. So like you get levels in the 30s, 40s, you get levels that are much higher than you do with arginine and glucagon. 5 is actually pretty, like if you're going to respond, 5 is very low.
So could there be a role in Lumos for growth hormone stim test in the future then?
That's a great question. I don't know. You'd have to talk to them about. I mean, there's masmorelin, which is also an oral growth hormone secretagogue and is approved in adults as a growth hormone stim test molecule. And there could be, I don't know if they're going to want to develop, like, I just don't know if they're going to want to develop that as a diagnostic agent.
Yeah.
I don't know if there's anyone from Lumos, you could ask them. But theoretically,
I think Duke is here.
Let's see, am I missing anything? I think those are all the questions in the chat.
And I think those are the questions in the room. Thank you very much for that wonderful talk and very interesting. So a few years from now, one more question maybe.
Sure.
Years from now, how do you see us approaching growth patients? And then I know it was in your conclusion, but how do you envision that?
Okay, so from the diagnostic perspective, already I think we're there where there are individual patients who, based on their history and their growth pattern, obviously you need to think about hormonal deficiencies, right? Like we can't forget that hypothyroidism, presents with severe short stature, significant hypothyroidism with growth retardation, growth hormone deficiency. We see those patients with ectopic posterior pituitary glands, who have significant growth hormone deficiency. Those are all going to be critical. But I think that you also, and this is maybe a talk for a different time, there are patients who, based on their growth patterns, based on their family histories, who you think this is more of a genetic condition. For some of those patients, I think doing a panel is going to be helpful to find genetic etiology, because then if you identify patients with NPR2 mutations or aggregate mutations or CNP deficiency or Noonan syndrome, there are going to be the potential for targeted therapeutics for those patients. And then growth hormone is still going to be a major player, in treating those patients. So I think that there will be additional options, and I'm sure they're going to continue to be, for some of the other collagenopathies and these more severe skeletal dysplasia, other companies are developing approaches. So I think it's going to be kind of a spectrum of treatment options, but this is not in the near future. It's going to take a long time still to get there.
Thank you. Thanks for your
Right.
time.
I hope to see you all in person soon. Enjoy the rest of the conference.